Welcome and good morning, everyone. It is 10 o'clock on this dreary Wednesday morning in Southeast Michigan, but that's okay. It's made a little brighter because we get to spend time with you all today. My name is Randy Lober, Growth Marketing Manager here at Action Benefits, and happy to welcome you along for today's session where we'll talk about CMS's Medicare rule for contract year 2026 and everything that it does and does not include. Joining me in support of today's conversation is Kevin Giralaman, one of our account managers on the individual team, perhaps even your account manager. Kevin, want to give you a chance to say hi before we get started.
Hey everyone, thanks for taking your time out of your day to spend with us, and I hope you learn a lot.
All right, thank you for joining us here. I know Kevin has spent just as much time in the rule as I have. We've dug around, figured out what matters most here to agents and the people that you serve and the people that we all serve here. So we'll get right into it. Title of today's session and the image you see on your screen is kind of apropos of, I think, how we collectively around the office feel about the rule. What's missing matters most. We have a bun without the hamburger. It's kind of meatless here today. Not in the sense of like we're promoting we're missing plant-based food or anything like that, but there's not a ton of substance to see in the rule here. And we'll show you why and where we're missing some things that might have been expected throughout today's session. But for those of you that are newer to the market or maybe just need a refresher why a final rule is important, let's talk a bit about what a final rule is. Generally, and this is a general pattern, not necessarily how it always goes, but generally, CMS, the Centers for Medicare and Medicaid Services, proposes rulemaking in the fall of each year. So November or so, again, typically speaking, in a regular year, CMS takes a look at what's going on in the Medicare market and thinks about some things that they might want to change to either improve efficiencies, better protect beneficiaries, make things simpler or smoother. I I don't hear you laughing at the moment because you're all muted, but you get the drill, right? CMS has the opportunity to kind of reshape the program over the next year or so. After CMS proposes rules, they say, here's everything we want to do and how we want to change the Medicare program for the next contract year. The public, you, I, and everyone else has 60 days to comment on that rule and say, yes, CMS, that's a really good idea, or no, that's not a great idea, or yes, but I like that rule, but have you thought about this, or have you thought about this in implementation? And CMS has a legal obligation to read all of our comments, and if not take them into account in the rulemaking, at least respond to why generally they did or did not accept some of those comments in the rulemaking. And all of that process comes together. CMS takes all that feedback, goes through all the comments, does respond to each of them, or at least those that follow these same threads of comments, and pushes their final rule out in mid-spring. So in mid-April, CMS released the contract year or the contract year final rule for plan year 2026. So what will come up here starting for us on January 1st. So that is the timeline we're talking about here. That's kind of the background, and anything that we talk about here today would either be proposed or go into effect for plan year 2026. So generally speaking, our agenda here today is we want to put these things in three main buckets. What was proposed and finalized that directly impacts how you do business? What was proposed and finalized that directly impacts consumers and how they experience the Medicare program? And what impacts the market more broadly? So it might not have an immediate, direct, tangible impact in how you do business, or it might not have an immediate, tangible, direct impact on beneficiaries, how they experience the program, but it could shape market forces around them and how the overall program changes. So that's where we'll spend our time today, and in roughly that order, we'll start with the hard-hitting stuff first. And to kind of showcase how the conversation will go here today, we'll highlight each provision. We'll name the problem CMS identified in the proposed rule, what it wanted to try and address. what the proposed solution was, and we'll tell you whether or not it was finalized as is or with any adjustments. So one thing, if this is not your first year in the industry, you know that last year there was a ton of lawsuits that came down against CMS on how they were going to handle agent and broker compensation, whether or not FMO override, so payments paid to organizations like ours, would be allowed to continue, and a whole bunch of other, items like taking away your compensation for health reimbursement, or sorry, wrong HRA, for health risk assessments and those items. So lots of stuff that was posed like that. Lots of lawsuits were filed, and what CMS ended up doing is amending the rule in the final rule and saying, oh, by the way, all the provisions inside this rule are severable. That means if you knock down part of the rule, the rest of the rule should still stand. So they acknowledged that all the chaos last year caused some uncertainty. They emphasized that the provisions of the rule are severable, meaning they can all stand independently of each other in case one gets struck down. And that was finalized in this rule here. Kind of gives us a good framework for how to understand how we're going to approach the remainder of the conversations here today. We'll look at the problem CMS saw, the solution they proposed, and whether or not that solution was finalized. So starting first with what impacts you, what would you see, feel, or hear as you go forward? The first problem CMS saw is CMS really and if we think about the timeline of when these proposals came down and when things were finalized, right? Everything that we're talking about here today was proposed under the previous administration, and everything got finalized by the current administration in the White House. So the problem that the previous administration identified was that they believed beneficiaries, generally speaking, not any of yours, but generally speaking, broadly, they're poorly informed about all their available options for Medicare coverage. And so what they had proposed was adding to that pre-enrollment checklist a number of things that you would have been required to discuss with beneficiaries before they sign on the dotted line and enroll in whatever plan they chose. They would have required you to discuss Part D low-income subsidies, to list out Medicare Savings Program and eligibility for them. They would have asked you to talk about GI rights for Medigap. And they would have asked you, again, that pre-enrollment checklist, to think about explain the implications and the impacts on coverage of switching from a Medicare Advantage plan back to traditional Medicare, if someone made that decision. What CMS did in the final rule was say, no, we're going to defer that till later. We acknowledge that it was a concern, but we remember that in mid-April, Dr. Oz, who is now the administrator of CMS, had not yet been formally confirmed and installed as the administrator of CMS. So essentially what they did is punt on this rule. They said, no, we're not going to do this yet. But they did leave the option on the table for them to come back and revisit that requirement later. So in short, it doesn't affect what you will do, see, feel, hear in this regard for contract year 2026 or your AEP appointments this year. But the door is open for further rulemaking. And as we've seen in the under 65 market, this administration does do some off-cycle, so to speak, rulemaking as they propose some changes there. So we don't quite know what will happen coming down the road. Things could change for AEP, but as of now, it remains status quo. Second problem CMS identified was they saw a lot of what the previous administration saw as misleading ads that skirted the content standard of the two elements that were required review by CMS. And they saw a lot of ads from call centers and so on that had the intent of inviting someone to start what they call the enrollment chain, to call us and to talk about your Medicare options and to find you a plan that fits you. And so what they had proposed to do was to remove that content standard and instead say anything that would cause a beneficiary to call in or to visit your office, right? Anything that would intentionally start that enrollment chain would need review by CMS. And that really would have broadened the scope of things that would have required review but from CMS. Much of the advertising you all likely do, where you say call to discuss your Medicare options or talk to me about your Medicare options, would have been captured by that rule change. Fortunately, for the time being, this change was not finalized, meaning your marketing strategies, your marketing content remain the same. You continue under the current rules for AEP 2025 and plan year 2026, but they did leave it open for later rulemaking, where they may revisit this content intent standard going forward. The other thing they had mentioned in terms of what you would see, hear, and feel is they saw a lot of both plans and third-party marketing organizations, which is the catch-all term for anyone who essentially sells or markets Medicare Advantage or Part D plans. They saw a lot of folks positioning those debit cards as a benefit, not as the how do you administer the mandatory supplemental benefits that are part of each plan. So you would drive around and see billboards for debit cards offering $500 a month or $600 a quarter, whatever the case might be, and really enticing beneficiaries in with, or you saw a lot of the TV ads for call centers advertising the same thing, enticing beneficiaries in for that $600 a month, no strings attached, whatever that benefit might have been. And that's really not the intent of the OTC benefits, right? Yes, it's to provide a health-related benefit for beneficiaries, but it's not meant to be a marketing differentiator under CMS's eyes. So instead, what they would have done is limited the ability to market that dollar value or the method of delivery. So they would have said you can no longer say you get a $600 debit card per quarter, or whatever the case might be, but you can say you have funds to pay for supplemental benefits. They would have stripped out both call centers and carriers' abilities to keep that as a top-level advertising item. This change was not finalized, though, but again, did keep it open for later rulemaking. So in the spirit of the bun without the meat here, in terms of actual impact on agents, well, there's not a ton. Kevin, I know there's some things you might have saw here in these rules, and happy to hear from our audience here on this as well. What are some other things that seem noteworthy at this point?
Well, I just wanted to touch on the fact that CMS believes members are poorly informed about all of their options. If you're ever with a potential client or preparing for a meeting and you're unsure about any disclaimers you need to provide, or if you need help confirming whether a pharmacy or doctor is in network, please don't hesitate to give us a call. We can walk you through all of that and answer all your questions.
Yeah, great point, Kevin, is that individual team is always here to help out and help guide you through everything you need to do to have a compliant appointment. And as you go back to those options for a minute, something sparked for me. If I come back here, all these options about low income subsidy, Medicare savings programs, GI rights, so on and so forth. Knowing those first two bits, low income subsidy and Medicare savings programs, can take you a long way toward helping your client find the right product fit. There are about don't hold me to the exact figure, but something like 19% of Medicare beneficiaries are also eligible for Medicaid, which likely make them eligible for either a Medicare savings program and or a Part D low income subsidy. And gosh, when you as an agent can help take care of them and make sure that they're taking advantage of all the benefits they may be entitled to under those plans, that makes for a stickier client and a client that will likely refer you elsewhere. So if you're not yet as comfortable with those concepts as you might want to be, please reach out to our individual team. They or I are happy to help walk you through those. Second big bucket of things we want to talk about here today is what directly impacts consumers. How will they see any impacts from this rule or from what was proposed and what is actually going into effect? One thing that CMS had proposed in the fall was updating the Medicare Plan Finder. They found it was often too hard for beneficiaries to verify provider participation in the plan. And what they also found is that carriers do provide a lot of, and plans do provide a lot of at-home or in-home benefits, but it's really hard to figure out who those providers are and who's in network with your plan is, right? They're often left out of a plans find a doctor tools. If they're not in the plans find a doctor tool, they're not making it into Medicare.gov for lookups. And so what CMS had proposed was requiring carriers to provide provider directories for upload to the Medicare Plan Finder. So beneficiaries would have been able to put in their doctors on the Medicare Plan Finder or Medicare.gov, figure out who participated with which plans in their area, and go from there. And they would have also been required to include those in-home or at-home supplemental benefit providers as well, so you can find out which home health care aides, for example, are covered by your plan and which are not. That provision, again, was not finalized. There's going to be a theme here, right? They deferred it for later, for future rulemaking. And I get the sense as I go through the rules and talk with you here today that a lot of it was just waiting for the new sheriff to be in town, so to speak, right? For Dr. Oz to have been confirmed as the CMS administrator and really be able to help mold and shape policy going forward. There is something that did get finalized, so perk up your ears for this one. Currently, when we take a look at vaccine cost sharing and insulin cost sharing under the Part D benefit, as part of the Inflation Reduction Act, the IRA required that cost sharing would be removed for adults and not subject to any Part D deductibles. And insulin cost sharing would be capped at the lesser of either $35 per month, 25% of the Medicare negotiated price, if the drug was one of the drugs that Medicare had negotiated for, or 25% of the plan's negotiated price. So at most, someone would pay $35 a month, but if the 25% of the negotiated price would be less than 25 or less than $35 per month, rather, that's the price the beneficiary would pay for that insulin product. No real problem to solve here. They were just implementing the law, and all of that was finalized in the rule here as well. So again, another educational point for your clients, that $35 cost share cap on insulin is in effect. Although if they're not paying $35, it's because of one of these two reasons you see here on your screen here as well. Second thing that did get finalized, so second yes that your beneficiaries will see, hear, and feel, and if I'm honest, this is probably one of the most impactful things your beneficiaries will see, hear, or feel. Currently, that Medicare Prescription Payment Plan, or the smoothing program, in common terms, the program that allows your Part D enrollees to spread out the cost of their prescriptions over the course of the year, like more so of a subscription model or a payment plan. Currently, we would have required beneficiaries to actively re-enroll in that program each year. And as you all know, sometimes it's even tough to get people in the door for AEP. Imagine how much tougher it would be for a carrier to get that beneficiary to re-enroll in a program or to opt back into the program every year. So CMS did propose that auto re-enrollments would be able to happen beginning in plan year 2026, and the beneficiary would have the right to opt out of the program at any time. And that portion of the rule was finalized as proposed. So going forward, if you currently have a beneficiary on a Medicare prescription plan, whether it's with a Part D standalone or whether it's with an MAPD, if they stay in the same plan next year, they will automatically re-enroll in the program. No need to take any action. But if they do change plans next year, they would need to re-enroll. Even if they stay within the same carrier, they would need to take action to re-enroll. So big takeaway for you there. if they renew passively, so to speak, they don't make any changes to coverage, they'll automatically renew. But if they do any active sort of renewal, they change plans even within the same carrier, they won't automatically re-enroll in this plan. Another big thing that caused a stir in the market was CMS had proposed covering anti-obesity medications or AOMs, like your Wegovy's, your Ozempics, those sorts of things under Medicare. Current law, as they saw it, does not allow Medicare to cover drugs specifically prescribed for weight loss, although the same drugs, depending on the carrier, can be used to treat type 2 diabetes, for example, but Medicare is not allowed to cover drugs that prescribed solely for weight loss. So CMS proposed solution was to reinterpret the law. Maybe the law doesn't say exactly what it says it does, and we find some wiggle room here to cover drugs just to treat obesity, and would expand that reinterpretation to the Medicaid program as well. So state Medicaid programs would have been able to cover things like Wegovy or Ozempic strictly for weight loss. This only got like a half a sentence mentioned in the final rule, but they chose not to finalize and did not leave this one open for interpretation going forward. Doesn't mean they can't, but all indications are, at least in the foreseeable future, that CMS is going to choose not to cover anti-obesity medications when prescribed solely for that purpose. Another thing that CMS had noted in the previous administration was behavioral health access was a challenge for some folks. Particularly Medicare Advantage enrollees, CMS had found, pay between $7 and $21 more for in-network mental health services. So think about appointments with either family therapists or individual therapists or couples counseling or even drug rehabilitation or things like that. On average, MA enrollees actually paid more than they would have than if they had just stayed in original Medicare. Opioid treatment copays for someone needing help with a substance use disorder, that was especially more expensive, $37 on average, more expensive than someone would have paid under original Medicare for that same service. So CMS proposed to cap cost sharing for Medicare Advantage plans at the same level that traditional Medicare enrollees would have paid. But again, continuing the theme here, this provision was not finalized. It was deferred for future rulemaking. So they did leave some definite opening to come back to this later on in future rules, but we did not finalize that this year. So if, for example, though, you do have someone who requires behavioral health care in those veins, that is something you might want to be aware of as you are navigating their plan options with them, that on average they could be paying a little bit more for those services than someone in just traditional Medicare. One thing that is potentially exciting here is that D-SNP enrollees, so those who are eligible for both Medicare and Medicaid and choose to enroll in a dual eligible special needs plan, they get they can experience or can have a really fragmented experience. They've got a Medicaid carry, or they've got their Medicare plan, their Medicare Advantage plan, that's the D-SNP, but they also may have Medicaid coverage, whether it's from the state or whether that's administered by a carrier. So they've got no fewer than 2 ID cards. They've got rules for both programs to try and figure out how to manage which card do I present at the pharmacy, which card do I give to my doctor, lots of different stuff, lots of different hurdles to using that care. And so where available, CMS did propose a few things to smooth that transition or smooth the usage of those plans for those enrollees. First thing they wanted to do was where someone does have an integrated D-SNP, whether it's fully integrated or partially integrated dual eligible plan, meaning that both the same carrier provides both the Medicare and Medicaid benefits. They wanted to streamline things and say that D-SNP enrollee only needs 1 ID card, not 2 for the 2 separate programs. And because both programs, Medicare Advantage D-SNP plans and Medicaid beneficiaries also are subject to health risk assessments to figure out exactly how risky the person might be when they come onto coverage. CMS did propose that they streamline those instead of having to have a separate HRA for Medicaid, a separate HRA for the Medicare Advantage plan. They said, no, one's good enough. Let's make this easy, especially if we're asking you the same questions both times. That rule was finalized, but the impact will depend a bit on whether integrated D-SNPs are sold in your market. Love to hear from Kevin and our audience at this point. Out of all the changes we've covered here, what seems most likely to help your clients going forward?
I think it's nice that the members who utilize the Medicare Prescription Savings Plan can now auto re-enroll, whereas previously they had to re-enroll themselves each year. I also want to point out that at this moment in time, Michigan does not have any integrated D-SNPs available, but when they become available in the state, I think it's convenient for D-SNP enrollees to just have one ID card to present when seeking care. And I mean, the less ID cards that a member has to keep track of, the better. Also, please contact us whenever your client needs a new ID or OTC card. I know how painful it can be to sit on hold with customer service, so please just let us handle that for you.
Yeah, great point, Kevin. Especially for D-SNP enrollees who, through no faults of their own, right? They get targeted by different folks from time to time, and they kind of churn and burn through plans. And although that plan switching, that SEP has been limited in recent years for them to change D-SNPs every quarter, they're no longer able to do that. They might still have some leftover cards hanging around, right? Not know which one to bring to the doctor. So they just bring their whole wallet to the doctor and say, pick one. Um, Let us help you take care of it and put the right cards in front of your member so they can use the coverage that you helped enroll them in. We also, when my computer cooperates, want to talk about what will impact the market more broadly here in our home stretch. First thing, which neither you or your beneficiaries see, but you can certainly feel, is medical loss ratios, right? As medical loss ratios climb, at least on paper, benefits tend to get a little bit narrower. We saw that this contract year, right, as carriers took on more responsibility with the Part D redesign. As we look into next contract year, we can probably see MLRs climbing even higher, which means, again, benefits might get a little more narrower, but that's neither here nor there. What happened is CMS saw that the calculation of MLRs in Medicare Advantage products in particular wasn't quite calculated the same way that commercial plans or even individual plans do that. There's different factors that they were able to include in their administrative costs or different factors that went into their medical costs, the numerator here of the MLR, so what goes above the dividing point here. They suspected that their current data collection strategies and that strategies allowed big conglomerates to manipulate medical loss ratios to make things look a little bit either better or worse on paper as may have suited their benefit design and need design for the coming year. So what their solution is or was to rework the MLR calculation to better align with how it does in other markets. So how you calculate MLR in, say, the small group market would have been the same as how they calculate MLRs in the Medicare Advantage market, would have given us more level playing field to discuss. They also wanted to gather more information about how vertical integration. So when a health firm owns the insurance company, owns the PBM, owns the doctors and hospitals, how that vertical integration really impacts MLR. Are they really losing as much money as they say they're losing on those MLR reporting? Essentially is what CMS wanted to know. That provision was not finalized. Either of those provisions were not finalized and did not seem to leave the door open for visiting that in the future going forward. One thing that may help your beneficiaries, though, although it also talks about the market more broadly, is some additional transparency in how folks deal with pharmacies. You, as agents, know this is a pretty common scenario where someone enrolls in a plan during AEP. They go to fill their first prescription on January 2nd, only for the pharmacy to say, "No, we're out of network as of January 1st. We no longer support that plan." And so what ends up happening is you and your beneficiaries you help beneficiaries make enrollment decisions based on a bad directory or bad information, right? You enroll thinking the pharmacy is going to be in network on October 30th, but you had no indication that the pharmacy was dropping out on January 1. So there's a problem. The other thing CMS wanted to do was they recognized that when the negotiated prices for drugs go into effect in January, that it's entirely likely that folks may not have access to them, especially if pharmacies, aren't as technologically advanced or in tune with the laws as they might need to be. So they proposed 3 new requirements. First, they proposed that any carrier offering Part D coverage must notify the pharmacy of their in-network status by October 1st of the prior year. Meaning before AEP begins, a carrier's got to tell the pharmacy, and therefore you would feel more comfortable knowing that the pharmacy would be in network for the next plan year. And they also would allow pharmacies to terminate contracts without cause of a with those carriers, as long as they provide appropriate notice to the carriers and to enrolled beneficiaries to give pharmacies a little more leverage, and especially independent pharmacies, a little more leverage in how they participate or whether they participate with these plans. CMS also proposed to require pharmacies of all types and all sizes to enroll in the Medicare Transaction Facilitator, which is really a big computer program essentially that helps list Part D claims and helps identify Part D allowed amounts going forward. And by requiring pharmacies to use that program, the hope is that everyone would have increased access to the drug prices Medicare has negotiated for those Part D drugs. All of those requirements were finalized as you see on the screen. So you can all rest a little easier this AEP, knowing that the pharmacy you said was in network in October will still be in network in January. CMS also saw that there was no strict guidance on how AI was used in Medicare Advantage, whether AI is being used to affect prior auth decisions or coverage denials, or anything else, underwriting for med subs and things of the sort. There was no real strict guidance on that. And there was some evidence, though they didn't go in detail in the proposed rule, that AI was making discriminatory care decisions. AI is, yes, it's computers, but it's also it was programmed by humans, right? So human biases and things might creep their way in. So their proposed solution was to require AI to comply with current anti-discrimination regulations and to make sure that AI could not discriminate on any factor related to a person's health status. So they could not, for example, didn't be pre-programmed to deny care for someone who is already incurring a lot of claims or who is already risky. So they wanted to be really careful about how AI was being used in those coverage decisions. That provision was not finalized in the rule. Didn't really give a lot of indication whether there would be more rulemaking around that. Another item, and the last item we'll touch on here today before we wrap up, is that health equity and prior authorization. So a big focus in the waning days of the last administration was taking a look at prior authorizations. Some of that has carried over to the current administration. You see there's a lot of appetite in Congress to regulate them. But the fundamental problem Congress and CMS has in regulating prior authorizations is that they don't know for sure who is being denied services or who is being denied via prior authorizations. Are those prior auths, do they tend to disproportionately affect different populations of folks? And so what CMS would have required was uh, carriers to report on a variety of different groups and demonstrate which populations were denied care and for what reasons, and for which services and line items they were cared. So they were denied. So if the prior, would we have found a pattern of, prior authorizations being denied to low income folks? Would we have found a pattern of prior authorizations being denied to D-SNP enrollees? Um, they would have required carriers to be more specific in that reporting, but again, that was not finalized here in the rule. And again, did not seem to leave a lot of room for that to be required in the future, though, again, as pendulums swing back and forth, it's certainly always a possibility. As we head into the home stretch today, Kevin, love to hear from you or anyone in the audience. What are some things that seem likely to impact the market at large?
I think it's a big deal that consumers will be fully informed of their pharmacy network before and during AEP. They no longer would have to deal with enrolling in a plan during AEP, only to find out that the pharmacy they wanted dropped out of network on January 1st. Our team fielded a ton of calls post AEP where this was an issue, and it's a welcome change that helps make life easier for the member.
If only they would do the same thing for doctors, right? I'm sure tons of you get that call as well, or for hospitals, for that matter. So, ladies and gentlemen, so what? What's the big takeaway here? And for us, the takeaway is while there are some things that certainly improve quality of life, like the auto re-enrolling in the Medicare Prescription Payment Program, like the ability for pharmacies know whether they're going to be a network. Those are kind of small, relatively quality of life things. But for as big as all those proposals were about, pre-enrollment checklist, so on, everything else we talked about here today, a lot of that stuff just didn't happen. So there's, as we said, this rule is a lot of bun, not much beef to it. That really impacts the way you'll do business going forward. But again, note that the continued implementation of that Part D redesign, climbing MLRs, all those things might lead to this AEP being just as rocky as last one might have been in terms of benefit adjustments and re-enrollments, but we will help you stay apprised of that going forward. Should also note that just as in the under 65 market, as I said at the top of the hour, this administration has shown the willingness at least to make some off-cycle rulemaking. So if there were a mid-year Medicare proposed rule or addendum to the proposed rule and then a final rule after that come out, I don't think anyone in this room should be entirely surprised if that were to happen either. Whatever the case, we'll keep you in touch and in the know about whatever it is we hear coming down from those agencies. All that said, ladies and gentlemen, we thank you for your time and attention here today. Should you have questions about anything you heard or just want to get in touch with us or need some servicing help, there's a few different ways you can always find Action Benefits. One is follow us on LinkedIn at the Action Benefits Company. You're welcome to email me at learning@actionbenefits.com or reach out to the individual team and Kevin's team at individual@actionbenefits.com, or always call our main line at 248-356-8585, and Brenda will do her best to find you the person that can help you the most. Kevin, before we wrap up today, any parting words for our audience?
No, I just wanted to thank everybody again for spending your morning with us. I hope you learned a lot, and I look forward to seeing a bunch of you this summer.
All that said, ladies and gentlemen, thank you again for your time and attention here today. Always happy to spend some time with you all every Wednesday morning or whenever we can. If there's anything we can do to help, please let us know by getting in touch with the numbers or contact methods here on the screen. Otherwise, I do wish you enjoy the rest of your morning and look forward to seeing you all again soon at another Action Academy session. Enjoy your days.